Good evening to all of you. I welcome on behalf of CAHO to this very important webinar. Today, in this era of pandemic, healthcare communication has gone for a big toss. And digitization and artificial intelligence has helped us a lot in circumventing the challenges and problems associated with the healthcare communication in the era of this bad pandemic. To speak much more on these aspects, we have two eminent speakers, Dr. Parivalavan and Dr. Arjun, very eminent speakers from down south. I'll be introducing the second speaker at a later date, but let me introduce Dr. Parivalavan Rajavelu. He is a surgeon by profession. He has also done his DNB and is a consultant surgeon and specialist in laparoscopic surgery at Sundaram Medical Foundation, Chennai. He set up the first emergency department in the private sector in India at SMF and nurtured it to become one of the best known academic emergency medicine centers in South India. He has done pioneering research with IIT Madras in diabetic food and has invented an equipment called pedo power graph to measure food pressure, which has done a wonderful job in diabetic food management. He is also the clinical head of quality assurance team at Sundaram Medical Foundation, Chennai, and he is the CEO of Skills for Med Patient Care Skill Center, Chennai, an organization that shares best practices with healthcare professionals to equip them with expertise to provide safe patient care. A very good friend of mine and a very fantastic speaker is there to speak on the topic of safety and digital tools for COVID-19, protecting your face and leveraging WhatsApp. Over to you, sir.
Thank you, Dr. Suneel. Am I heard? Am I audible?
Yes, sir. You are audible. You can go through.
Okay, sir. Thank you so much for those kind words, sir. Thank you for the introduction. Actually, there are two topics in today's webinar. I'm going to talk about the healthcare workers' safety, and Dr. Arjun Rangarajan will be talking about leveraging WhatsApp. So I've been giving this webinar a few times. It all started, when all of us faced this COVID-19 and we were learning the ropes. And as a quality head, I was actually heading the whole response, the corona response in our hospital. So I was actually considering myself as a role model in terms of wearing the PPE, the mask and the visor and things like that, so that everybody, I want to set a role model so that everybody can follow, because I'm the quality head. But I actually, was struck with corona, and I was really surprised that, with all these precautions, how did I get this? Because I was taking precautions both in hospital and outside as well. And the words of one of my senior nurses actually, really shook me. She said, apparently, somebody told me that, she told to her friend that if Dr. Pari has got corona, then I have lost all faith in PPE. So this really set me thinking, and 14 long days of isolating yourself, I did a lot of introspection and read a lot of literature and learned a lot about how the COVID-19 spreads. And this talk is a result of that introspection. So I wanted to share with you. And after coming back from that quarantine, we have put in, before the quarantine, our healthcare infection count was almost 45 in our hospital. But after that, after putting these measures, I'm going to talk about the incidence has come down sharply, and it's hardly 1 or 2. So I think there's important lessons to be learned. So I'll be happy to share that. So let me start my presentation now. So can you see the presentation?
Yes, sir.
Thank you, sir.
You can go ahead.
So my emphasis is on healthcare worker safety for the COVID-19 pandemic. And I'm going to talk about 6 topics. So the first one is about understanding behavior. We need to understand how the virus actually behaves. How is it different from the other viruses? So actually, I would say coronavirus is a genius, and that's the reason it is spread all over the world. And next, we have to understand the behavior of us, the healthcare workers' habits, which unfortunately, we are not able to change quickly to respond to the virus. And that's one reason it is spreading. The other is, all of us know, but I'm just going to touch upon the modes of spread just to emphasize. And the second part of my talk is about prevention of spread, how to do source control. And this is the main chunk of my, or I would say the meat of my talk, though I'm a vegetarian. It's called the face protection. This is an acronym we have coined, and I'll explain to you when we come to that. And finally, I'll end up talking about PPE policy and training. So when we talk about understanding behavior, so we have to understand how the COVID-19 is different from the other coronaviruses. So COVID-19 virus is affecting the humans for the first time. So we don't have any immunity, or we may have little immunity. Still, we don't know much about it. So this is the reason, before going into prevention, we need to understand how the spread of this virus is different from the spread of other coronavirus, like common cold and other, SARS virus, which you've seen before, and how our unchanged habits is a catalyst for spread. So if you look at how the normal common cold virus spreads, there's usually an incubation period of 7 days, and the disease lasts for anywhere between 7 to 14 days. And the infective period, or the period of spread, is 2 days before the onset of symptoms and during the disease. So it's about 7 to 10 days. So the infective period before the onset of disease is called the pre-symptomatic phase. And the disease phase, when it spreads, is called the symptomatic phase. So we are all familiar with this, nothing new about this. And this is how the common cold virus or the other coronaviruses are spreading. So we have the pre-symptomatic people who don't yet have the symptoms spreading it, and the symptomatic people who have the symptoms spreading this. But how is COVID-19 different? So it also has the same thing. It has the pre-symptomatic and symptomatic. And here is one more term you have to learn, and that is the never symptomatic. So many of these coronavirus infected patients, or the COVID-19 infected patients, have very mild to mild symptoms. So they don't actually report sick, and they keep carrying on the normal activities. And this never symptomatic group, which actually spreads a lot of this disease, because when we have symptoms, we actually quarantine them. So there are 3 groups of people spreading this virus. One is the symptomatic group. The next is the pre-symptomatic group. And the third, which is a new one for this virus, is the never symptomatic group, who are mild to moderate, very mild and mild symptoms. So as I said, the symptomatic group we are catching. We are all focusing on the symptomatic group. We are doing the screening. The moment, we find they're symptomatic, we immediately put them in a COVID care center or COVID hospital, or we put them in home quarantine. And therefore, the ability to spread is limited. Whereas the pre-symptomatic and never symptomatic group silently spreads the disease. And this is the reason this virus has become the pandemic. This is a very, very important information about the virus all of us need to understand. And this is probably the reason, I got infected. I realized that before, because we had a lot of these meetings, all of us now have these meetings about how to do things. And we are not taking that precautions amongst ourselves. So that is the problem. So if you see, 60% of patients of the spread happens by pre-symptomatic and never symptomatic, and it's only 40% happens with the symptomatic. And undetected spread, corona is laughing all the way. It just, we are only focusing on the symptomatic patients. Meanwhile, the COVID is, spreading along these pre-symptomatic and never symptomatic patients. The other problem is we have patients with atypical symptoms like, nausea, vomiting, diarrhea. They come to the ER with, AGE, or they may have a stroke, they may have myocardial infarction. We have seen several of these patients in our own emergency, or sometimes they present with conjunctivitis or skin manifestations. So these patients also spread the disease. And finally, there is RT-PCR is the gold standard, but unfortunately, even this test is at best is only 80% accurate. That means 20% of them may have a false negative. What does that mean is when the test will show it's negative when the patient is actually positive and is infected. So this is also a problem. Now many hospitals put strict things saying we will only admit only after testing the patient, but we have to understand you will miss 1 out of 5 patients who are positive even while you do the test. So this is not actually a very good strategy, though it has to be done, but it's not a very good preventive strategy. So many hospitals have this. Now we have the COVID ward and we have the non-COVID ward. So we'll see what happens in these non-COVID areas. Amongst other patients, we have pre-symptomatic COVID-19 infected patients who are not screened, but they don't have symptoms. We have patients with atypical symptoms of COVID-19, and we have the never symptomatic COVID-19 patients, and finally the RT-PCR negative patients who are actually positive. So we keep working amongst all these patients, and you can imagine what is going to happen to our safety. And that is the reason so many healthcare workers are getting infected, because we seem to think that the non-COVID area is not that important to have the same safety as in the COVID areas. So first thing is we have to forget that there is no non-COVID area. There are only 2 areas. One is COVID positive, where the test is positive, and the rest of the hospital is all suspected COVID. The attenders, the patients, your colleagues, consultants, help, the vendors, all of them, each one of them who enters the hospital is suspected COVID unless proved otherwise. So this is very, very important for us to understand. So a uniform prevention and safety policy is necessary, and this has to be put in both areas of the hospital. So this is my first point, that you have to understand the spread of the virus, how the virus spreads among the pre-symptomatic and never symptomatic patients, and this will help us to put a uniform policy. The next is the understanding behavior of ourselves. What is that habits of the healthcare workers which is actually making us spread the disease? So we can hear many of these news that there are several doctors who are getting these are all senior consultants who are actually not going to the ward. They're only supervising. They're also getting infected. And canteen, in some canteens there is has become hotspots. So what we have found is the infection happens really not at the patient care area, but actually outside the patient care area. This is very important. So why does this happen? Let's quickly look at this. So traditionally, over so many years, we have been taught there are 2 areas in the hospital. One is the patient care area, and the other is the healthcare area. WHO has based its 5 movements of hand hygiene based on this concept. So when you go to the patient care area, there is infection, and therefore you should wash your hands and do all the safety measures. So when we come out of the patient area, we relax, and we the barrier between the patient care area and the healthcare area, which has been true for so many years. It has been true, and that is our habit. So when you come outside the patient care area, we do the handing over, we go for rounds, we sit, we have meetings, we simply sit and chat and gossip, we celebrate birthday parties, because now we spend a lot of time in the hospital, and our social activity also happens within the hospital. And this is our habit. We think that precautions are only for patient care areas. But this is not true in COVID-19, because healthcare workers ourselves are infected, and therefore this whole barrier between the patient care area and the healthcare area is not there. So we need to consider the whole hospital as one pandemic area. There's no distinction between going to the patient and coming out. This is a habit which is very, very difficult to eradicate, because we're so used to it. The moment I finish the surgery and come out, immediately I go to the lounge, and then I want to chat with my other co-surgeons and all that, and we don't maintain social distance. And then we remember, oh, no, let's keep a little bit apart. So it is a habit ingrained in us. So this is the reason why a lot of spread is happening amongst the healthcare workers. So anyone can spread the disease everywhere. So the virus is present in every area of the hospital, and that's something which is worth remembering. So here I wanted to bring in the concept of airline industry and safety. We always said the airline industry is doing safety so well. And I always thought that is because if the plane crashes, the pilot is also going to crash along, with the other passengers. And that's the reason the pilot and all the, air hostess and everybody was so careful about the safety, because their life is also at stake. And here is a scenario where we are in the same boat or in the same aeroplane. Okay. If we don't take the precautions with everyone, including that security man, including that housekeeping person, then we can get infected. So safety is for all. So that is the point I wanted to make here. So there is a huge paradigm shift needed here. So not only patients, any one of the health workers can be carriers of the infection, and precautions apply to all of us. It's not just because I'm a consultant, I don't need to wear a mask. I'm the medical superintendent. I don't need to when somebody comes to meet me. Now, anyone who comes into my room can be infected. And this should result in changing your habits, because when we lower the mask, we don't know. Maybe I'm infected, or maybe the other person is infected, and I can get infected. We have to always be suspicious. So we need to be actually antisocial. It's a very sad, isn't it? 2020 has become an antisocial year. So we need to constantly adhere to the safety measures from entry to exit. All non-patient related direct personal interactions, like meetings, seminars, classes, simply sitting and having tea, lunch, all this is can spread the disease. If at all you need to have direct meetings, restrict the number of people and maintain social distancing. Another important thing, which is very sad, is when you are going social gatherings outside. For example, one of our OT technicians went for a funeral. Promptly within 2 days, he got infected. So it becomes our responsibility also to stay away from the social gatherings outside the hospital. Very, very important. So I talked about the virus behavior. I talked about the habit of healthcare workers, which is making the disease spread. And finally, I wanted to just touch upon the droplet and contact and airborne spread, which this virus seems to be doing all three. Usually it's only one, isn't it? So here is a good, nice diagram which shows how the spread is happening. So mostly with droplet in close contact, and the droplet land directly in your face or nose and you get infected, or it lands on the surfaces, and when you touch the infected surface and put your hand on the face, you get infected. These are the two major modes of spread. So how do you prevent it? Person to person, social distancing, cough etiquette, wearing mask and visor, surface, disinfection, perform hand hygiene, and wear gloves during patient care. Simple. But these are the simple measures which is not done consistently, and that is a problem. What about airborne spread? Still, the final word has not been confusing evidence for and against it. People are challenging the WHO. WHO came with a clarification, but we know as much as Ebola and other viruses. There is some airborne spread, especially when there is aerosol generating procedures like nebulization, BiPAP, NIV, endotracheal intubation, etc. But whether airborne spread is a major cause is the current evidence it is not. But still, there may be some element of airborne spread, and you have to wear a full PPE and N95 mask to prevent it. So we have looked at all these information necessary for us to now get into the preventive aspects of how to do it amongst ourselves. So the first is source control. So source control is, of course, we always say it is a patient. I found I had to do a find and replace in my PPT, because in every place it was patient, patient, patient. But we know it is not only the patient. It can be the patient, it can be the doctors, it can be the housekeeping, it can be the ward boy, it can be anybody, or it can be the visitor, the vendor. So anybody who walks into the hospital is a source. So that is very, very important to understand. And all of anybody who comes into the hospital should wear a 3-layer mask, which should cover the nose and mouth. And whoever is not wearing a proper mask, this happens again and again. Even today in my clinic, I had a couple of patients who were working with masks so thin. It looks like actually one of those wheels. The beautiful women wear. It's to look more sexy. So these type of masks are being worn, which is useless. So we have to again give them new masks and at entry itself to make sure everybody is wearing a proper mask. So the screening should include looking for the masks which are appropriate. So let me go into the screening. Usually we talk about the symptoms, but I think we should start with the mask and then ask them to perform hand hygiene. And now, because so much of RT-PCR test is being done, also ask about whether they have already done the test. And based on that, you segregate the patient. If they're positive, they go to a fever clinic, or they have symptoms, they go to the fever clinic. Only the rest can go to the general area. So this is a mild or double layer of screening which you have to do about the mask and the hand hygiene. So this is the usual screening questions we ask. So once we talk about source control, the next is about the face protection. So this is what is advertised. So what is this face protection? This is the protection which each healthcare worker has to undertake to protect himself or herself from this disease. So let's look at it. This is an acronym, as I told you. Each letter stands for a particular protection measure. F stands for face and body protection, masks, face covers, gown, gloves, etc. A stands for air circulation to ensure proper ventilation. Keeping all the windows and doors open, ensure there is cross ventilation is very, very important. And C is cleaning and disinfection. And finally, E is engineering controls. So usually, we are focusing only on the PPE. But I think face, instead of saying PPE, I think for this COVID-19 pandemic, we should say face protection, not PPE. Okay. So let's look in detail about what each of these components. So face protection starts with goggles. I'm coming from top to bottom. So it provides eye protection. So you have goggles, you have visors. So you can either wear goggles or the visor. But now, having read the evidence and also looking at a very logical or common sense view of this, the goggles is only protect the eye, whereas a visor gives you protection, and it also protects you from touching your face, automatically once you wear the visor. So for these two reasons, the visor is better than just wearing a goggle. So these are the available options. Several visors available. Available. They are anywhere between 50 rupees to about 200 rupees. And I think every healthcare worker has to wear a visor along with a mask. So coming to the mask, they have the 3-layer mask and the N95 mask. Unfortunately, this has got the valved variety, which is which you should not use. So the 3-layer mask, the specifications or the testing is not that intense. But the N95 has got to go through a very rigorous testing process before it is certified as N95. Whereas the 3-layer mask, these is not that rigorous. So especially with India becoming ramping up its local capacity for making masks, there are several manufacturers serious doubt about the quality of this 3-layer mask, and one test shows that the protection offered ranges anywhere between 10% to 90%. Average is about 50 to 70%. So that is the problem with 3-layer mask. It is actually sufficient for drop, but because of the certifying as a 3-layer mask is not that rigorous, the quality of this mask is so variable. Whereas N95 is certified only through a rigorous process, and therefore it always offers 95% protection. Therefore, when there is a doubt of whether it could be airborne, I think it is err on the side of caution and wear your N95 or even standard. Some people wear two. It is always said that you have to wear an N95 mask and also a mask over it. It makes sense because contamination of the mask from outside is less. It was very difficult. I'm sure most of you who have worn both masks find it difficult even to climb a flight of stairs. Whereas if you have the N95 mask and the visor in front, It serves the same purpose, and therefore your protection is also good and your breathing is also much easier. So this is the available mask, the 3-layer N95. These are the common varieties. Again, no, I'm taking any cut from any of these manufacturers, but these are the common ones available. And this is what we use. And this is something which I wanted to bring up: improper mask wearing. I'm sure all of you would have seen these sort of varieties of people coming with mask wearing. So this is why it's very important to and make them wear the mask properly. And most of the people have the habit of lowering the mask while talking, and that is the most important time where you have to wear the mask, because only when you're talking the droplets keep coming out. So let's go to gown. We have the full PPE or the coveralls, which offer full body coverage. The surgical gown only offers cover up to here, but now we have separate face and hood covers also available thanks to our Indian manufacturers. It is much more comfortable than wearing a full suit, and it serves the same purpose. So I would say that surgical gown, especially when you're in non-AC in other areas, it's much more comfortable and gives the same protection. But if you are able to convince your frontline workers to wear a coverall, that's fine as well. So the other question asked is gown necessary? So there is a Cochrane review saying in May 2020, there is very low evidence that covering more parts of the body apart from the face is leading to better body protection. And also there's a danger of contamination when you don't remove the mask properly during doffing, or many times you find people wearing the full PPE and coming in and out of the restricted areas. So this is a problem. There is a danger of contamination. But remember, both WHO and CDC recommend the use of clean, non-sterile, long-sleeve gown for COVID-19. So we can't go against that. So you can have a rational policy. So you can have all the confirmed COVID. Yes, you need to wear the gown. In suspected COVID, you could have a policy where you look at the length of the exposure. For example, if I'm just going to say hello to a patient on a round, in a suspected COVID area, does it make sense to wear a gown? Whereas if I'm going to do a minor procedure which is going to last 30 minutes, of course I have to wear a gown. Before I was only wearing a plastic apron. Now I wear a full sleeve gown. Similarly, the task, as you know, if it is an aerosol generating procedure, you need to wear a gown. If it is non-AGP, you don't need to. So each hospital has to think about this very carefully and come up with a rational policy, or you have a universal policy of gown everywhere. So these are the available options. You can have either single gowns, or you can have the PPE kit, which has the whole thing, or the coveralls. So the gloves, nitrile gloves are preferred, but if you don't have them, latex serves well as well. But the important point is you should wear the glove only during patient care, because this is another mode of spread. If you wear the glove and keep opening doors and touching all of the surfaces, and you don't do hand hygiene, then it spreads much more than not wearing gloves. So therefore, insist that the glove should be worn only during patient care. Now, so F is over. So A is airway ventilation. You need to keep all the air, doors and windows open, maintain cross ventilation. If you are sitting in a clinic, sit close to the window which is available, if available, and ensure the airflow is away from you. So what I've done in my clinic is, I open the window behind me, put a table fan so that the air blows away from me to the door which is open opposite to me. If you have the option and you have a window opposite to you, you can put an exhaust fan opposite to you. So again, the air flows away from you. So in this way, even if patients come in and go out, the airflow is always again away from you, and thereby you can minimize the droplet spread to your face. So this is that's why I said PPE is important. That is F, but airflow and ventilation is equally important. Cleaning and disinfection has been emphasized so much, but I'll just I think some quick tips, because these are very practical. Foot operated dispenser is very useful, and take off all those sheets and put only the Rexine, and the pillow is also covered only with the plastic sheet which can be removed. Patient, we use 1% hypochlorite to disinfect this area. So WHO is clearly spraying and fogging is unnecessary and harmful. UV light is making a big comeback, but again, the current evidence is it is an additional method of disinfection. The primary method should be surface disinfection. On top of it, you add UV. Yes, it sort of has an additive effect, but UV alone is not recommended. So 1% sodium hypochlorite, cheap and best, clean surfaces of all patient-related equipment and high-tech surfaces, and it has to be prepared freshly using bleaching powder or germoclean tablets. So some engineering controls are also important. For example, I have this chair which is away, 4 feet away. I put a so that if some patients, usually the patients have a thing of drawing the chair close to you. So I say, see, look at this tape. You should not come nearer than that. And all our attenders and the visitors, we have put a shamana outside, and they wait outside rather than inside the hospital. And pharmacy, we have a runner system where in front of the pharmacy, the patients or the attenders just give the prescription, tell the pharmacist what is the quantity needed, and then they come and wait outside. And then once the medicine is packed, they go and deliver the medicine outside. So these sort of small innovations can be done, and engineering controls can be done to prevent the infection. So this transparent partitions are also very, very important. And these need not be very expensive. Just you need a wooden frame with a thin plastic, and these can be put in where in the patient reception areas, and even in the fever clinics where the interface between patient and actually the suspected patient who's coming for a review for the COVID test and all that. It helps to prevent the droplet spread. Of course, engineering also includes technology. So you use video conferencing or teleconsultations, give variables in the COVID ward so that the nurse doesn't need to go every time to check the vitals. So all these also help one of the things we forget is the time of exposure. So it has been proven if it is less than 15 minutes, it's not a high risk exposure. So therefore, we should do everything to reduce the time of exposure to COVID positive patients. So we looked at the spread of the COVID and the mode of spread, the source control, and the face protection. Protection, A is airflow and ventilation, C is cleaning and disinfection, and E is engineering controls. Finally, let me finish by quickly looking at policy we can have in the hospital. So it is very important. Initially, we went through this phase. We had 4 areas, and we had low risk, high risk, moderate risk, and very high risk. This sort of thing, very confusing. And the implementation was difficult. The the workers also, the healthcare workers also found it difficult, to do anything. So now we have sort of, put it only into 2 areas. One is the COVID-19, and another is suspected COVID-19, and becomes much easier to implement. So this is an example. So we look at the dress, the gown, head covers, shoe covers, mask, face covers, and gloves, and the area. So we club COVID-19 and high-risk areas in the other areas. So these high-risk areas, the dress is hospital scrubs. The other areas is uniform or own dress. Protective gown in the COVID-19 and high risk. Head and shoe covers, yes. Mask is N95 for all areas. Face cover, visor is for all areas. And gloves only during patient care, all areas. So in this way, it's much simpler to implement and also to adhere to. So reuse of PPE can be done for goggles and visor, only in the not non-COVID, suspected COVID areas, whereas in the COVID areas, they are also disposed of. So training is this is something which, we know, but we are seeing that every time I take this, class to our hospital employees, I do it in Tamil to the, housekeeping people. Immediately, I'll find the next day when I go, everybody's wearing the visor. But within a week, all the visors are missing. So this is something which needs to be, reiterated again and again. So training is for everyone, and there's no person who should not be trained about this. And this is a common training material. What I have been talking is a common training material, but you also need to have relevant training and job cards for each. I'll just tell you what those cards are, but use the same FACE acronym for these also. So basically, we divide the staff into 3 categories. People who come first into contact. These are the security patient relations, and they come in contact with the patients, visitors, and vendors. So So all these, we have educational material for these people. The second is doctors, nurses, physiotherapists, radiology techs, phlebotomy techs, housekeeping, ward boys, who cannot maintain the social distancing. We have to go near the patient. We have to examine the patient. The ward boys have to transport the patient and also give bath to the patient. So they cannot maintain social distancing. So how do they do taking safety precautions? And then there are other group of staff who can maintain the social distance, like billing, pharmacy, dietary, medical records, admin and management. So we have a different group of job cards for them. So in this way, we are covering the whole hospital. So this is my, message of what I learned. And as I told you, this is my introspection of when I got infected. So let me just quickly tell about the skills for patient. 2 minutes, Dr. Suneel, sir. So we started this mainly because we are having the problem of the nursing turnover. So we thought we should come up with some solution. So this is mainly we help to establish your own in-house training program to keep your doctors and patient happy. So this is called Train, enhancing training ability in-house. So we help all hospitals to enhance the training ability, and we run these courses for graduate nurses, nursing educators, and for nursing assistants and specialized nursing courses. So this is our team, and we are now offering free online training for the COVID heroes. So the first talk is what I'm giving for the doctors, hospital admin, and owners. My nursing educator gives regarding nursing safety and paramedics. And we also run an online donning and doffing workshop. So if any of you are interested, please contact us. You can go to the website and message or phone number and call us. Very happy to spread this knowledge to your staff. Thank you so much for the opportunity.
Thank you, Dr. Pari, for that lucid presentation. Very informative, yet very simple and easily understandable. And it reminds me of the saying that it is better to prevent and prepare rather than repent and repair. Thank you for experience-based medicine when the evidence-based medicine is going for a toss for different ways. And please stay back online. We would like to see more of your face, because if we come to your hospital, probably will not be able to see your face with mask and face shields. So please be online. We may be having a few questions at the end. So please be online. We'll be having another talk by Dr. Arjun Rangarajan. He has done MBBS and MPH in public health. He is a public health professional currently serving as the Director for Strategy and Global Partnership for Noora Health, an NGO based in Bangalore with operations in 6 states in India, Bangladesh, and the United States of America, focusing on driving improved health outcomes for patients and family caregivers by enhancing organizational impact and scale. Arjun's past experience has spanned healthcare management, public health research, and program implementation at Harvard's Brigham and Women's Hospital, Doctors Without Borders, and the Center for Disease Control, CDC. Arjun completed his MBBS training from Sri Ramchandra University in Chennai and a Master in Public Health from Emory University, Atlanta. So he'll be speaking on the topic of today, that is safety and digital tools for COVID-19, protecting your face and leveraging WhatsApp. Eminent speaker, Dr. Arjun Rangarajan, very focused and fantastic speaker. Dr. Arjun, over to you.
Thank you, sir. Thank you, Dr. Suneel, very much for that introduction and for the opportunity to share here. Thank you, Dr. Pari, as well for bringing us in to this webinar and being able to share our materials. I'm just about to share my screen, and can everybody see my screen here now?
Yes, sir. You can go ahead. No problem.
Fantastic. So as Dr. Suneel mentioned, I represent Noora Health, and Noora Health, just to give you a little bit of background, is an NGO based out of Bangalore. We're about 6 years old, and we currently operate out of 6 states in India and have recently launched our work in Bangladesh as well. The main goal of what we do at Noora Health is really to provide education, not just to patients, but to caregivers as well. So to family members, to attenders, to those who accompany the patients on their visits to the doctor, And as I'm sure all of you are very keenly aware, often it is the family members and the family caregivers who have a large role and impact to play in the recovery of that patient, in helping prevent complications post-discharge, and also in helping ensure that there are better outcomes and better recovery after a visit or after an admission or after a procedure. This has become even more so important now with COVID, as you all know, and a lot of the data which also shows that the main source of infections are family-based clusters. So really this notion of improving care and improving education and really driving behavior change for family members and family caregivers has become so much more important within the realm of COVID, and remains important for so many other health conditions that we are still grappling with, and that in addition to COVID, it's kind of become a new dual burden, if you will. So just to give you a little bit more, flavor of what we do and where we work, like I said, our focus is really on the family members and the caregivers as part of ensuring health behavior change can happen, not just at that moment in the hospital, but that continues to happen. As Dr. Pari was also saying, reiteration is such an important element of ensuring that the correct behaviors and the right preventive practices are not just shared at an initial moment, but that they continue to be practiced over time. So we do this by providing a number of different things to our partners. We work a lot with state governments. We also work with some private sector institutions, including the Narayana Group of Hospitals and Manipal Hospitals. And what we do runs the gamut from developing really engaging dynamic content, training nurses, social workers, and others to provide this training to patients and family members directly. We have implementation teams that work on the ground and who continue to support the work at an implementation level. We do a lot of WhatsApp-based follow-up, and part of that is really going to be the crux of my talk today in terms of a specific service that we've developed to help in the COVID response. And the last really big leg of what we do is to ensure that we are measuring and monitoring what we do so that the programs themselves are impactful, that we have the right data and evidence to know, what we are doing, is it working or not. This just gives you an idea of where we are. And over the last 5 years, we've had an opportunity to train nearly 700,000 patients and family members across these states. So that brings us to what's happening with COVID. And as you all know so well, it's changed how we practice medicine, how we deliver care, and how we're able to deliver our services. So for an NGO like us that focused on educating patients and families in physical hospital settings, a lot of our work was also impacted, including that which was done in collaboration with state government partners. And so what we felt is that we have an opportunity to really drive some of this positive behavior change for at-risk communities by being a little bit more creative in how we got the message out and how we shared some of this key health behavior change messaging and information. So our first step was to really find out from these many districts across the country what really is happening on the ground. What are the things that people are worried about? What are their fears and anxieties when it comes to COVID? And therefore, how can we target the correct messaging in a way that really makes a difference and is able to answer those questions that patients have? And part of this is also helping devise that script for healthcare workers, whether they are nurses or physicians or community health workers, to know what are the key messages that one must impart to patients, and one must sort of spend time on to ensure that those concepts are well communicated and those education elements are conveyed as part of any patient visit, right? So what were some of the interesting things that we found? And if you notice, there's a link on the slide, and I can share it later if anyone is interested. So all these survey results are available for anyone to really read through. But we found that, for example, while there was a lot of information out there and patients were aware of COVID, they were not necessarily aware of the spread. Dr. Pari was talking about asymptomatic spread as well. And we found that, again, there continues to be a need to emphasize preventive behaviors, to emphasize messaging around masking, to emphasize messaging around social distancing, and many of these key preventive behaviors that can have an impact. So we included this in our curriculum for nurses who are delivering this at the facility level. We created content in 12 different vernacular languages. We started to train frontline staff, and we also used WhatsApp in many ways to really assist not just with the response for patients, but also help assist providers themselves, healthcare workers themselves, to have the information at their fingertips. Now, again, as you all probably know well, it's not easy to keep track of all the information that's coming out. It's very dynamic. There's a lot of it, and there are many sources through which it's coming. It's challenging in the middle of practice and in the middle of everything else that is going on to keep tabs on, say, the Ministry of Health website, or more accurately, probably everyone is receiving multiple WhatsApp forwards and PDFs of what the latest guidelines are, what the latest circular that's come out from the Ministry of Health or from ICMR. So keeping tabs on all of this is a big challenge in and of itself. This just gives you an example of what some of our content looks like. We've created this, in terms of catchy videos, digital infographics, audio. Again, this is in multiple languages and all in the vernacular. And we've integrated this both on the patient front as well as on the physician front. So if you are a provider, who needs to give health education material out to the patients that you're seeing at your institution or at your clinic, we've made this available for people to be able to share, so that they don't need to then go through the creation process to identify verified, reliable material. All the content that we create is vetted through an experienced medical team and is in line with Ministry of Health, ICMR, and WHO guidelines. So in terms of the WhatsApp piece that I want to spend a little time on, what really is the need? And again, this is not something that I need to explain to this group, but there's already such a huge burden on the system, and there are lots of information gaps in terms of getting the right information to caregivers at the right time. So how can we help address this? What we came up with was a WhatsApp-based support line. You may have heard the term chatbot. This is similar to a chatbot where basically, you just save the number that you see on the screen to your phone, and you message it a hi on WhatsApp. And what you get, and I'll show you a demo in just a bit, is a quick overview of all the key and essential clinical guidelines and information that you will need, and that will help manage, triage, provide information on testing, as well as provide information on hospital and facility level maintenance in a way that is easily accessible, quick, and which, obviously is in a methodology that everyone is using in terms of WhatsApp. So this is, again, just to give you a sense of what some of the user interface looks like, what some of those essential guidelines cover. For example, you just want to know quickly, and you may not recall, what are the typical radiological findings, right? This is something you can quickly go in, get the information for. You may want to know a little bit more about what are the initial steps of managing an acute patient when you're still assessing for COVID positivity. And this is something that we're able to provide a quick algorithm for within the scope of more of a primary care kind of focus. So really keeping in mind even the referral pathway that's been laid out by the government. I'm going to go straight to the demo so you can get a sense of what this looks like. Please let me know if anyone has any issues as this plays. So what you see here is someone beginning to message the bot. They get the first set of menu options with a bit of an introduction. And you can basically get more information by selecting any one of those numbers. In this case, we want to know a little bit more about some of the key guidelines. And as you can see, for example, this person, maybe they want to know more about contact tracing and what that might mean for them in terms of an understanding of what is the pathway that they need to follow for different categories of COVID patients. Again, this is all based on Ministry of Health guidelines. And so it really helps aligning your own practice with what the guidelines are saying. You can go back to the menu at any time. You want to know a little bit more about a different area. So as you can see, there's a lot of information in this bot, but the key feature is also that it's a single source, easily available, easily navigatable. We've also added in additional resources and materials. Some of these are custom made illustrations that we've created that include algorithms, that include diagrammatic illustrations. Others are guidelines and documents from the government or from others that are available online and include the latest scientific evidence and research. And there are ways in which that you can continue to add to your practice. We've linked out to abilities to do training courses. And from here, this gives you another example of what some of our visual content looks like. So just to sort of start wrapping up, what makes this service really unique is the fact that, this is not a training platform. We've made this available for free as well. We're supported by philanthropic donations that allows us to provide this as a free service. And so there's no charge to the clinician at any point. You don't need to download another app and familiarize yourself with how to use it. It's WhatsApp based. It's a single source where you can get all this information. So just to give you a sense of how things have been going with it, we've only been sharing it pretty much through word of mouth. It's been seeing steady increase in usage. We really feel that it can help reduce confusion and provide and be a just-in-time assistant for providers. This is a quote from a gentleman in Karnataka that we work closely with. We did some surveys among some of our users. We found that 100% of them would want to share it with their colleagues, and an overwhelming majority found it both useful and easy to use. We're planning to roll this out in regional variants as well. So it will be available going forward in Kannada, Tamil, Hindi, Punjabi, and Bengali. We also plan to include live support elements. There will be a team of largely nurses and some physicians who can help support. We plan to add elements of mental health support as well, and more options for people to pursue training if they require or are interested in training. So we've curated some essential training opportunities that they can access through the bot. And we will continue to add more visual content to make it really easy to read and easy to understand. So that brings me to the end of my section. You can see the number again on your screen here. So please feel free to try it out for yourself. Our website is on as well, and my email address. So if anyone is interested in learning more about this or would like to share this more broadly with either your own institution, your own clinic or colleagues, you're most welcome to and happy to connect. So thank you, Dr. Suneel and Dr. Pari.
Thank you, Dr. Arjun, for your presentation and taking fantastic initiatives in the era of challenged communications, because non-verbal communications have gone for a toss with these masks and PPEs. So it definitely does a lot of help for these challenges which we face in the healthcare delivery. Thank you so much for the presentation. I think we can take a couple of questions. I think there are a couple of questions to Dr. Pari. Sir, your experience about N95 compliance for proper use over extended periods of 8 hours duty, reuse and authentic supply.
Yes, sir, that's it's a problem. All of us know. See, basically, the supply has become better now. When we started, it was quite difficult to get N95 masks because we're all used to, the 3M masks and things like that, which, we were in short supply. We were told that, everything went to China. But now the supply has eased. And we also found that the medical grade N95 mask and the other industrial N95 masks, there's not much of a difference. For example, the 9504, 3M 9504, which we use, it's about 70 rupees, I think, 50 to 70 rupees for the hospital. So it is the same N95 quality, and it has got the same FFP2 certification. So with this, we are able to provide N95 masks for the whole workforce. Before, the masks were very expensive. They're about 200 to 250 rupees. So we were rationing the N95 masks and asking other people just to wear the 3-layer mask. So now the policy is changed, but if anyone is not in close contact, as I told you, there's 3 categories. So when social distancing is possible, that group of staff, they will just wear a 3-layer mask and a visor. Whereas the others who go near the patient, they wear the N95 mask and the visor. So that is one. Reuse, again, All India Institute has come up with a good plan. They give 5 masks at the beginning of the month, and every week, the masks are changed. I mean, every day, on day 1, you wear the first mask, day 2, you wear the second mask, so that each mask, is air dried for almost a week. We know that the COVID-19 stays in the surface for about maximum 2 to 3 days. Some people say 1 day, again, as it any other thing with COVID, there is confusing data. So they actually, the air drying happens for almost a week, so it's very safe. But we found it very, very difficult to implement it in the hospital, because you give them 5 masks, they forget some at home, they say, I didn't bring the mask. So these are the things that are happening. So with this, the cheaper masks, we have told them that, we'll give them 2 masks at a time, and so that they get 3 days of air drying, and then they keep using it. So that way, there is more control on the mask usage. So the other thing, what is the other question about N95?
Authentic supply.
Supply is better, as I told you now. The problem is, I'm not against making in India. There are several masks available, but in terms of N95, it is not just the thickness of the mask. There is also this, electrostatic property of the N95 mask, which repels these viruses. So I really, don't know whether those tests are done. So, we still see, it's like, maybe because I'm a surgeon. So if there are certain sutures which I've been using for years, these are imported, right? I don't know to say the company's name. But then an Indian company comes and says, use our suture. I would gladly use it for the skin suturing and all that. But when it comes to suturing the intestine, I will not compromise, because the result is devastating if that suture gives way. It's the same thing with covering your nose and face with the mask. If the mask is not proper, then you get infected. So that part of it, we didn't want to compromise. And I think, being the quality head, I was responsible in pushing, the hospital to spend a little bit more money on N95 masks for the whole staff.
Thank you, sir. To add confusion, I have seen people wearing N95 mask above 3-layered mask, or the vice versa. What is your take on that?
Yeah, all sorts of combinations.
So what is your take on that?
The logic of wearing the 3-layer mask above the N95 is to prevent contamination, the droplets staying on the surface of the N95 mask, because you're going to reuse it. But what I'm saying is, use the visor instead of another 3-layer mask. It serves the same purpose, and the visor can just be washed with soap and water. And whereas the disadvantage of the 2 masks is, 1 is expensive, and 2 is very difficult. And I tried it for some time, and I couldn't climb 2 flights of stairs. I'm not that unfit. I can climb 3 to 4 flights of stairs without a problem, but I found it very difficult.
Yeah. One more question. What precautions should be taken for lab technicians for in-house labs?
Same, sir. This is again the problem. See, when I had the infection and I went for blood testing, the lab tech was not taking any precautions. Okay, they were just coming like usual and wearing just a 3-layer mask and doing the test. And I think as I said, it has to be uniform. There is nothing, you don't segregate between lab techs or security or housekeeping. All of them get the same masks, same protection. I think the primary thing is the mask and the visor. That is universal. The glove only during when you are touching the patient, and then you discard it. Okay, these 3 things are universal. Whether you wear the gown or not, or shoes and all those things, they can be sort of rationalized.
more question. We have always used fumigation with the D125 in operation theaters. Why not consider whole hospital as OT clean zone and fumigate after periodic timing?
So we don't do fumigation, sir. And none of the developing countries do fumigation, because it has been proven that surface cleaning is the best way to get rid of any bacteria or virus or spore. Fumigation can be, first of all, no, we stopped using, what was that? We used to use the formalin fumigation. No, it was so harmful. But even the current fumigation is harmful because the aerosol is spread. So fumigation and spraying, it's not my opinion. WHO and CDC categorically say no. We have to use surface disinfection, and fumigation. Surface disinfection has to become more intense. The housekeeping has to be given a timetable where it is done much more frequently than before. That is what we should do, not fumigation for the whole hospital. Sir. This government spending, I'm sure, lakhs and lakhs of rupees in spraying and fumigation in the streets. I'm sorry, it's such a waste of money.
Thank you for the clarification. One more question. What is your thoughts on reinfection and herd immunity?
Sir, I'm not an armchair. There are several WhatsApp armchair experts, and I really don't know.
More confusion rather than conclusions in this.
Yeah, we have to wait and see.
Yeah.
Only thing I can say is we did the antibody test for our hospital. Only less than 10% of the people who are infected actually had antibiotics. But we don't know what is the significance of that.
Any use of UV sterilization of N95 intermittently between seeing two patients?
Yes, sir. The UV sterilization, they say, is as I told you, it's an additive method. You do surface cleaning, but you also have a UV light in your, in a patient care area, or it adds to it. Suppose the surface cleaning has done 60 to 70% of the work, UV can bring it up to 90, or more. So that way it is helpful. But please do not rely only on UV. See, every time a patient sits in my couch and gets up. See, this is another thing I wanted to point out. I forgot. Each area, that person should be responsible. You don't expect the housekeeping person come and do the job. So my nursing assistant in my clinic, as soon as the patient gets up from the couch, she sprays the 1% hypochlorite, does the surface cleaning before the next patient comes. So that is more important.
Okay. There's one more question. Does reusage of 3-layer N95 mask reduce its efficacy?
3-layer or N95, sir?
Reusage 3-layer / N95. Both there.
That's what I said. If you can use the logic of using the 3-layer old N95 was to extend its life. But the same thing can be done with the visor. The visor and goggles people don't use because of the fogging problem. That is a problem. I do agree. I have overcome it by putting a micropore tape on top of the mask. It is very painful every day when I remove it, but it prevents fogging, because in surgery I cannot afford to have fogging. So I put a broad micropore on top of the mask, and puts my specs on top of the tape. It doesn't fog. But I don't know whether everybody will be willing to do that. Sir, I can't hear you.
One more, I think we'll take this last question. What type of masks are recommended for the hospital staff who work in non-clinical areas? Are homemade domestic cloth masks safe?
This again was a question asked by one of my administration people, because they actually are in a separate building. So they are in a separate building. She called me and said, "Is it okay for us to wear cloth masks?" And this is, after that I gave this talk to them. So I said, no, you have to, it does not matter where you are, because you have vendors coming, and you will have to wear the same N95 mask. And true enough, the what can you say? The person who's looking after that house, he became COVID infected, and 6 of that staff got infected. They were living in they were actually working in a separate building, no contact with patients. So remember, this is the message I wanted to give you. It's not just patient care. It is any person who comes into the hospital can be infected. So the best protection you can have at this time is an N95 mask. And if you don't have an N95 mask, at least a 3-layer mask and a visor. So that is the minimum you have to use everywhere.
So there are no more questions. I think we can wind up the session right now. Thank you very much, Dr. Arjun and Dr. Pari, for your very lucid and very simple presentations, very clearly understanding the facts and figures. And also, in this era of challenged communication, we really have to put our foot down and see how best we can deliver the healthcare to the patients who come to our hospital. And also, the message is very clear that SMS strictly has to be adhered to. SMS, when I say sanitization, mask, and social distancing, it gives a really a very good protection, a very effective way of preventing the spread of this COVID-19 viral infection. Thank you, sir. Thank you, sir, for the participation.
Thank you so much. Thank you.
So I thank CAHO for giving me an opportunity to moderate this fantastic section, and all the very best. Stay safe. Thank you.
Thank you, everyone. Take care.